I'm Dr. Bing, you know me. I forgot to send the slides in advance to Dr. Broadhead to review, so you're stuck with me giving the lecture today instead. But last time we talked about the abdominal fast. I think everyone is pretty familiar with the FAST exam, and you all know the E-FAST because you've seen it done and you know the concepts. But we decided to split it up into the abdominal and then the E part, so like the chest part of the E-FAST, so that way we have time to talk about each in depth rather than throwing all this information at you at once. So today we'll put it all together for the chest part of the E-FAST. So we know the abdominal fast is, the purpose of it is to make the decision clinically, is a patient is hypotensive after trauma, do they need to go for an XLAP because of intra-abdominal bleeding? And then the extended part of the E-FAST was added after the initial abdominal fast protocol was adopted in trauma centers and for surgeons, where we realized that a tension pneumothorax and a cardiac tamponade can also cause hypotension and also require immediate intervention in the ER. So this was added on as part of the protocol because it doesn't add much time to check for these things. You've probably seen it done fairly quickly in the ER setting and trauma setting. And it gives you so much information because we know that a patient can be hypotensive not necessarily just because of intra-abdominal bleeding, but because of a pneumothorax, tension pneumothorax, or because of tamponade. So these are the two views that you would get, the lung view and the subxiphoid view of the heart. Are you able to see okay over there?
Yes.
Yeah, we'll get into some more detailed images of both and talk about how to get them, but this is a general picture that you'll be seeing while you're doing these scans. In this one, there's lung sliding here, which is something you're looking for, and then none here. And the main question when you're looking for pneumothorax is that you're seeing if they're lung sliding, la. And then for tamponade, you're looking to see if there's any pericardial fluid around the heart. And that's for the subxiphoid part of the fast. You're not really looking too much at the anatomy, looking at the different chambers. You're just asking the clinical question of could this patient's hypotension or instability be because of a pericardial effusion, meaning a tamponade. Okay. So before we get into the details, we're going to talk about why does a lung ultrasound look so different than the abdominal ultrasound. This is the main reason why we decided to split the E-FAST up into two lectures, because in the abdominal fast, you're looking at these organs that look like the organ. So when you look at the kidneys, it's in the shape of a kidney. You look at the liver, it's in the shape of a liver. But when you look at the lung, suddenly it doesn't look like lung anymore. And for me, at first, this was extremely confusing. I was like, why does these other organs look like the organ and you go to the lung, it doesn't look anything like a lung? And the reason is because of, like we talked about during the first day, you get a lot of artifacts when you encounter air. So there's a lot of kind of complicated physics behind why that happens. We don't need to get into the details, but we just need to know how to use these artifacts to our advantage. So when ultrasound encounters air, it causes these reflections of the pleural line. So here's a video of an ultrasound of the lung. So here's the soft tissue, here's the pleural line, and then these are reflections of the pleural line. And that happens when the ultrasound encounters air. So these lines, which are called A lines, they're not actually there in the lung itself, but they mean that there's air. So the main reason why your lung ultrasound doesn't look like the shape of a lung, and you don't see the bronchioles, you don't see the bronchuses come out the way you see the liver. In the liver, you see the blood vessels, you see the hepatic veins and arteries. So you would expect in the lung to see this too, but you don't. And it's because the air gets in the way. So the main way I remember this is that air interferes with ultrasound, and then fluid enhances ultrasound waves, which is why we have to put gel before you put on the ultrasound. And there's even ways that people will put, for example, if you're looking for ultrasound of the hand or the foot, they'll submerge the patient's hand in water and then ultrasound over the water. And this fluid enhances the wave. So in the abdomen, you have more interstitial fluid, and it helps and the organs contain more fluid. So you're actually seeing the organs look like the organ, whereas in the lung, you just get all this air artifact. The good thing is we can use this to our advantage, so we know that A lines means air is present. The trick though is not to assume, so an A line in a normal lung that's expanded means it's a normal air-filled lung, which is what we want. But if there's a pneumothorax, it's also air, so you can also see A lines in pneumothorax. So if you have A lines, it doesn't mean there's no pneumothorax, it just means there's air present, and you're actually looking at something else called lung sliding to determine if there's a pneumothorax or not. So to evaluate for pneumothorax, you have to focus on the pleural line and its movement. So here's the anatomy, your soft tissue, your ribs, which correspond to these ribs here, and the rib shadow. In this image, they have a part where the pleural line is not touching, and then it touches here. But a normal lung would look like this, where the parietal pleura and the visceral pleura are touching. And then when the patient breathes, the pleura slides against each other. So you get this shimmer effect. So this is a normal lung ultrasound, where they are oriented sagittally, like the probe would be like this. There's a rib, and then in between you get the pleural line, and there's actually this movement. Some people say it looks like there's little bugs crawling, little ants, and that's considered normal. You can see that sliding. So that means that in this area, at least, there's no pneumothorax because the lung is expanded and it's touching. So for pneumothorax, you want to look at the most apical area. If the patient's sitting up like this, often you'll go even to the clavicle, to the first and second intercostal space, and look up here, because the air will travel up, and that'll give you the most sensitivity if there's a pneumothorax or not. If they're laying back like this patient, then usually go to it's like the second or third intercostal space, just wherever it's the most upward, like the most apical section. In contrast, if you remember when we looked at the right upper quadrant, right, and the left upper quadrant, you're looking at the most basilar dependent areas to look for the hemothorax, where the fluid would fall. So, again, the steps that are traditionally taught are that you look for the two ribs, and then look for the space between the ribs. And I mean, this is a really good illustration of that shimmer. You can also look at it. It's also look horizontally once you identify the rib, and look for lung sliding that way as well. Usually we teach the longitudinal way first, because then you can identify the ribs and then the pleural line in between and know for sure you're looking at the pleural line. Whereas when you go transverse, sometimes you can be a bit off from the pleural line. Also, different probes, actually this is a better illustration, different probes can give you different views of what's going on. The most sensitive will be the linear probe, because you're zoomed in, it's more superficial. I think these two are linear probes. This one I'm not sure, might be cardiac. But when you're looking with, when you're busy and you're looking at the EFAST and you've already used either the cardiac probe or the abdominal probe to look at the other organs, it's also appropriate to first look with that same probe, so you don't have to take time to switch in between. But if you can't really tell what's going on, if it looks a bit difficult to see the lung sliding, changing to the linear probe or to the lung setting, if you have one of the handheld ultrasounds that has like a lung setting, then that will help give you more detail. So is it easy to see these pictures? We could go through them and decide whether there's lung sliding or not. So this one, what do we think? I'd say it's a little bit harder to tell because it's not in the linear probe, it's a little bit more zoomed out. So this one, I think there is a shimmer. I think there is lung sliding, but in this, if I saw this in real life, I'd probably switch to the linear probe or go to the M mode setting, which will show you to help you kind of find out for sure. In this one, what do you think? So here's the muscle wall, like soft tissue, skin muscle. Here's the pleural line.
Intact. Sure.
And you can see that there's like this little shimmer here. And you can tell that although the concept of it is easy in theory, like the concept of it all makes sense, it actually can be subtle because you're looking for a specific type of movement. And it can be a little bit hard to tell. Another part that makes it difficult is that when the patient's chest wall is moving, there's going to be movement. Like you're very rarely going to find like a patient that has no movement at all, and that's not a good thing. So it can be hard to tell. For example, this one, what do you think? So here's the soft tissue. No movement, right? Yeah, so this is no lung sliding, pneumothorax.
Pneumothorax.
Yeah. And you can see that when the patient is moving their chest wall, like trying to breathe, when they're short of breath, there's still movement.
The muscle is moving.
Yeah.
Yes.
So that can also be
The
because a little
costal
bit
muscles.
exactly.
He's trying to survive.
Yeah, it's like
Yes.
help. But
Bing, can I ask a question?
yeah.
So down there where you see the shimmer,
Mm-hmm.
is it the two pleural surfaces superimposed on top of each other?
Yeah, so
They're
it's
just going like this? So it's not like they're going like this, it's like this is what you're seeing, and that's normal?
so I guess what you're seeing is yeah, so like the visceral pleura will stay still and then the parietal pleura will be moving underneath. Maybe I have the names mixed up, but it's like this. So when they're touching, you see them moving against each other, but if there's a space, then you're gonna no longer see that movement because the air will be there and then the air will get in the way of that image.
Okay, thank you.
Yeah, good question. Right, and then this is another way to help differentiate when when it's a bit confusing, we're not really sure. I would probably do that on this image to be more sure. And then we talked about on the second lecture what in mode is. It's the motion mode, and what it does is you take. So this is your view of the lungs, like they're using a cardiac or abdominal probe, and then you have your image here on the screen, your regular ultrasound image. So the soft tissue, the muscle, your ribs, and then your pleural line. So it takes this line. So you place a line here with in mode. The line takes all the signal, and places it here. So it takes that here. So see how it's dark here? Now it's dark here. This bright spot came here from the muscle. This spot came here, this gray spot. And because this is all the chest wall, there's less so there's still going to be some motion on the chest wall because the patient's going to be moving their chest wall to breathe, but there's less motion. And because of that, when it takes this line and graphs it over time, it stays relatively straight, like relatively still. And then meanwhile, below the pleural line, because of the lung sliding itself, it's gonna cause motion. So that's what it's down here. It looks like from the motion, and they call this the beach sign, where the seashore sign. So here's the seashore, here's the sea. There's some fishermen out here, and then this is the sand. And then if you have a pneumothorax, that motion. So instead of you having two different signals, where it's still up here and moving a lot here, you instead have more of a straight lines throughout, like no motion throughout. So there's still like some motion because the patient's still moving a bit. You can see it's not like exactly all the same, but you can tell there's definitely a difference with the motion here. So they call this the barcode sign, where this looks like a barcode going across. Does that make sense? And then again, you don't freeze the image before taking in mode. You have to keep the motion going in order to do that graph of the image over time. So. Another special finding you can get when looking for. Yeah, so here's a CT. Another special finding on ultrasound you can get when you're looking for a pneumothorax is something called a lung point. And what that is if you look at the CT, like this is a CT still the definitive testing to look for pneumothorax. It's the most sensitive, right? But you can tell that when you're looking for ultrasound, you're looking at one place in time, on one part of the patient, whereas the CT will show the whole area. This is our three-dimensional view of what's going on. So if I was to ultrasound here, there'd be no lung sliding. Over here, no lung sliding. If I were to ultrasound here, there would be lung sliding, which is why we're looking at the apical part when we're looking for pneumothorax or not. But if you were to go right here, what would you see? If you were to go where the lung is partially there, where the lung is. Sorry.
At the moment, lost the here.
So you would notice that part of the lung is moving and the other one is not moving. And in between there is like a lung bone. The bone between the moving and not moving.
Right, perfect answer. So you would actually see part of it moving and part of it not moving, and that's this here. So this picture, see how the lung kind of comes into the view and it comes out? So you're actually catching part of the lung while it's sliding, and then here there is no lung sliding. So that corresponds to if you were to put the probe right here. And that's actually 100%, if you were to see this, it's 100% sensitive for a pneumothorax as a finding. It's like pathognomonic for a pneumothorax. And this is what it would mean in real life, where like in an illustration where this is where there is some sliding, and then here there's no slide. So where you find the lung point can also tell you how big your pneumothorax is. So if your lung point was up here, then it'd be a smaller pneumothorax. That means the lung comes up here and touches up here. If it were to be all the way down here, then you have a big pneumothorax. So it gives you some information. But then mainly I feel like this is a good illustration of why you want to go to the more apical part of the lung. Does that make sense? Yeah.
What does a hemothorax look like?
We'll get into that in a little bit. So B lines we'll talk about briefly. This isn't like there's a lot you can get into with lung ultrasounds. There's a lot of findings you can